So, Dr. Noor, this is the second day of the first antibiotic.
Yes.
Okay. Good morning, everyone, and welcome to the second day of the first Antibiotic Awareness Week lecture series. Today we have two presentations. The first presentation will be on antimicrobial consumption and resistance trends, which will be presented by Dr. Noor Shamas, an ID clinical pharmacist and antimicrobial stewardship pharmacist from Infection Control here in Riyadh. Dr. Noor, welcome, and the floor is yours.
Okay. Good morning, everyone. Thank you, Dr. Hajar, for introducing me this morning. So I hope you've all enjoyed the first lecture on Sunday by Dr. Hajar about vancomycin and aminoglycoside use. We also had yesterday our symposium. I'm not sure how many of you have attended both. So today, as Dr. Hajar mentioned, we're going to have two presentations, this presentation from 9 till 10, and then there will be a break from 10 till 12, and then the next presentation will be by Dr. Henry Bafobani at 12. So starting off, I'd like to just mention how antimicrobial consumption and resistance trends as a topic in general is very, very wide. We're going to try to cover just general concepts that can help everybody here in the audience of different backgrounds and different interests identify how this information can help you. So all this week we're talking about antibiotic resistance, the antimicrobial stewardship program, and how we all have a role. So, okay, we all have a role in the activities, but how do we understand the outcomes? So the objectives of this talk now is to understand first the need to follow antimicrobial consumption and antimicrobial resistance. So why do we have this lecture? Why is it important that everyone is involved and not just 5 people in leadership and a biostatistician that need to be involved with this? To also identify the available metrics that can be used to follow the consumption and resistance trends. So by metric, I mean the word comes from meter, which means it's an evaluation, a way to evaluate something, the impact of something, and then finally to understand the interaction between antimicrobial consumption as a metric and resistance. So I'm going to go through some fundamental topics that you may have not attended. For those of you who didn't attend the presentations yesterday, I know now we're talking about antimicrobial resistance and antibiotic use. So this all, of course, ties into stewardship. And stewardship is defined as the careful and responsible management of something entrusted to one's care. So if you've thought about this before, how can you utilize whatever resources you have in your vicinity in the best way possible? So this applies to, like mentioned before, stewardship of natural resources. So for example, water, electricity, oil. If you can see here, very simply, a small plant that can be used to feed millions of people. How do you make sure that the also that medications, and specifically antimicrobials, are available for everybody and not overused and not abused? So this is the word stewardship. It's just another word for wise use of, or in order to maintain a specific resource. So taking a step back, what is the goal of an antimicrobial stewardship program? So we know stewardship can apply to your salary, it can apply to water and resources, it can apply to resources at the hospital, such as the masks, such as syringes, such as medications. And specifically, antimicrobial stewardship talks about improving clinical outcomes because of the concern and fear of antimicrobial resistance. So with resistance and inappropriate antimicrobial use, we want to make sure that a patient that comes in with, let's say, a motor vehicle accident does not necessarily get inappropriate antibiotics on admission because someone thinks they may have pneumonia, where it's clearly not a pneumonia, it's clearly, let's say, due to the accident. So this is the way we want to optimize the clinical outcome of this patient. We also need to make sure to minimize unintended consequences of antimicrobial use. So also in the same thought process, if your patient comes in not requiring an antibiotic and they receive an antibiotic, what possible side effects can they develop? Is it a simple rash or antibiotic-related diarrhea? Is it a seizure or an allergy? So if the patient didn't require the antibiotic, the risk for these side effects will, from the first place, not occur. Last but not least, as a goal for a stewardship program is reducing healthcare costs without adversely affecting quality of care. So a cost can be associated with the cost of the medication itself, but also the cost, for example, of a hospital-acquired infection due to MDRO. So MDRO stands for multi-drug resistant organism. So when we talk about reducing costs relating to MDROs, we also talk about originally reducing inappropriate consumption and appropriate hand hygiene and infection control practices, as well as antimicrobial consumption, in order to reduce the risk of the patient acquiring an MDRO in the first place. So the part on costs can be really huge. So why look at trends or metrics? Metrics are there to help you visualize how an intervention is affecting your outcome. So if we now, when I was talking for the past, let's say, couple of minutes, it's been very difficult to see what I mean by optimizing clinical outcomes, reducing costs, reducing risk of adverse events. But when you see a graph, for example, when you see numbers, it's a lot easier to visualize what your intervention, how your intervention is changing any outcome, regardless of what the outcome is. So in that case, metrics can help you visualize the impact of an intervention on patient outcomes, the adverse events, and cost. And this is clear in recommendations by Joint Commission, Sebahi, and the Ministry of Health of Saudi Arabia that stewardship programs need to exist and they need to be able to monitor performance improvements and to be able to identify how interventions are improving or even possibly worsening antimicrobial or resistance trends. Also, in order to just solidify this concept again one last time, it's important to see some recommendations from local institutions or local recommendations. So this is a great article published in Environmental International, which looks at the antimicrobial resistance in the Gulf Corporation Council region. And if you can see, the objectives here of this study is to identify how resistance is affected by multiple factors from a One Health approach perspective, but also to give recommendations on what the solution is. So we all talk about the problem, but how do we solve it? So for example, here, the first objective is raising awareness, which is what we're doing at this moment during this week and hopefully continuously on antimicrobial resistance, to also strengthen the knowledge and evidence base through surveillance and research. So this is where this topic falls in. Surveillance is what we're talking about. When you identify what your trend is, you know where the problem is and how to improve it. And of course, there are recommendations on sanitation, hand hygiene, infection prevention, optimizing the use of antimicrobial medicines, and last but not least, investing in new medications and diagnostic tools and vaccines and other interventions. I'm sure you've been all following the COVID vaccine updates, so I hope that in the future you'll also follow resistance trends and also identify how the new medication use and abuse can also impact MDROs, and which are just as important as COVID. So now that we've discussed why it's important to look at resistance trends, to identify also what exactly do we look at when we look at resistance trends and consumption, we need to kind of plug it into an approach. So how do I approach surveillance and stewardship hand in hand? So there are many recommendations on how to approach surveillance and resistance trends and stewardship. This is just one of them. And the first item you can see here in the red box is assessing your facility's current state. So like I said, if you don't know the problem, you won't know how to fix it. So what do you assess actually? You can assess aggregate antibiotic use, rates of resistance, common clinical infectious disease syndromes, antibiogram development, and of course this is in addition with the use of IT infrastructure if available. Metrics can be quite complex if you don't take a minute to just understand the concept behind them. And it's important to decide on the optimal metric. So do we use antibiotic usage just as an absolute value? We used 10 grams of meropenem the past year. Or do we use another metric? And we also need to find a way to capture and calculate the metric easily. So where can I get the data from? How can I make sure the data is valid and validated and accurate? So in that sense, we can talk about process measures, outcome measures, and antimicrobial use measures. So, for example, a process measure can be one that assesses an intervention that determines the quality of antibiotic use. So, for example, we can talk about adherence to a certain recommendation. If, let's say, we have a stewardship program recommending certain recommendations within a certain setting, such as, for example, ICU, we need to be able to assess how good is the uptake of the recommendation, and also to assess other things such as adherence to clinical guidelines. So this is the first type of metric that we're not going to really go deep into today, but I just want you to keep it in the back of your mind. It's a process metric that identifies the quality of antibiotic use. The second metric is a type of metric is an outcome metric. So you identify financial, microbial, and patient effects caused by a healthcare process and intervention. So for example, you look at length of stay, mortality, or antimicrobial resistance. How do you bring these two together? So let's say I've identified that you have a ward, a specific ward that has a relatively high length of stay for your patients. And then you have a stewardship intervention that, for example, recommends IV to PO or recommends discharge on OPAT, which is outpatient parenteral antimicrobial therapy. So you basically, if let's say this ward houses long-term patients, and we know that for many reasons, we expect that these long-term patients are there because of prolonged IV use of antimicrobials. We try to find ways to fix that. So let's say you have identified your outcome metric, length of stay. You've identified a possible recommendation, which is IV to PO or OPAT. And then you look at how you can link these two together to reduce length of stay and eventually reduce cost, reduce the risk of antimicrobial resistance developing in those patients, and discharge the patient early. So the next metric, which is also focused on today, that we will focus on today, is antimicrobial use. So we have discussed length of stay and, for example, IV to PO and OPAT, but what if we send this patient home and this patient is going to be receiving, let's say, 20 more days of antibiotics rather than 10, which was recommended by the treating physician initially. So this is why you also need to identify and follow antimicrobial use metrics. So I'm going to give you an example here. Of course, we're talking about large facilities. So in general, talking about one patient is not going to be good enough. So most of these metrics are usually patient independent. So that means I'm going to look at the patient consumption, but I don't care about patient identifiers, which means I can get my data. So let's say if you look here, the green hospital A, has used 300 grams of meropenem. This is utilization data independent of patient information. I don't care who the patients are that used it at this point. Hospital B also used 300 grams of meropenem in 2019. If this were an interactive presentation, I would have asked you, would you be able to say that the consumption of Hospital A is the same as Hospital B? And in most situations, some people in the audience will say yes, because it's the same consumption, absolute consumption. Some would ask me, or possibly suggest that, what about the number of patients or number of beds in these hospitals? So let's say I tell you now that Hospital A or Facility A is a 100-bed facility, and Facility B is a 500-bed facility. So clearly, they have the same consumption, but they have a much larger opportunity for consumption in Facility B. So clearly, Facility A uses more antibiotics than Facility B, or the other way around. Facility B uses less antibiotics, less meropenem specifically in this case. So this is why we need to standardize metrics based on certain, basically standardized evaluation. So a group of people came together and said, all right, how would we most appropriately describe antimicrobial use after adjusting to certain criteria, such as number of beds, patients' length of stay, we will talk about those, the denominator, in a second. So when we talk about standardizing metrics, we can standardize it based on a preset denominator. The most famous ones are patient days, which is the number of admissions during a designated time times the average length of stay. So the number of patient days cannot be, of course, more than the maximum number of beds. So what I mean is, if you look here at Facility A has 100 beds. So in a month, you can't have more than 100 times the 100 beds times 30 days. This is your maximum patient days. In this specific case, we're talking about average length of stay. So you need to also get some information about length of stay and multiply it by the number of admissions. Admissions can also be a denominator, which is the number of patients admitted during a designated time. Days present can be another denominator, or a way to standardize the data, which is days present is different from patient days. Days present talks about the number of patients in a facility at any time during a day, during a calendar month. Regardless of whether these metrics are 100% clear to you or not, the point here is that you need a denominator that that the community agrees on, that says, all right, when I talk about my metric, I'm going to divide it by patient days or admissions or day present, and this makes the visualization a lot clearer. So I know that these details can be a bit overwhelming, especially if this is the first time you take a look at metrics. So we're going to talk about things from at this point on a very practical way. So how do you get your data? How do you use it so that you can get this outcome? So for starters, you need to decide on which date range you're analyzing. So for example, you can say that during 2018, you didn't have good data because you changed from one electronic order system to another. So you can exclude 2018 and choose 2019. Or you can choose the month of May or 10 days in June, depending on what you are requesting the data for. You then look at you can try to get the data stratified by ward or unit, name of the antimicrobial. You need to get data on the strength of the antimicrobial, the dosage form of the antimicrobial, the quantity of the antimicrobial that was used. By the way, dosage form is just basically meaning, is it IV? Is it a tablet? Is it a solution for an oral solution? So this is what dosage form is. The quantity of the antimicrobial that was used would be the next most important part, which is what quantity have you used from the antimicrobial, and then the cost of the antimicrobial that was used, which is an additional data that can help you with your analysis. So one important question I recurrently get is, what kind of antimicrobial usage data can you get? Of course, you can see here in the red right-hand side, you have logistics consumption records, which basically asks your purchasing data. How many vials of meropenem have you purchased in the past year? Pharmacy consumption records, which may be more accurate because it may reduce any risk of including, let's say, meropenem that was expired. So it's an actual pharmacy consumption records. But if you think of the medication use process, a medication is bought, it's sent to pharmacy. Pharmacy sends the medications to the wards depending on a prescription that was verified. After it was verified, the medication may reach the ward, but it may not reach the patient because at the last minute there was a change in recommendation, or the patient was transferred or discharged. And this is why the best type of data you can get is patient administration records. One really interesting way to get it is through barcoding. So in some facilities, they have the ability to, including ours, here in National Guard Riyadh, you can basically have a medication that has a barcode on it, and the administering nurse would scan the barcode on the medication on, let's say, the IV bag, on the bag, and then she or he would scan the barcode on the patient's wrist. So this way you make sure that this patient actually received the medication. So in summary of this slide, you need to get your data. The antimicrobial usage data source can vary in accuracy, but if you don't have patient administration records, it's completely fine to start with logistics consumption records. So now that we've talked about how to get your data and what data to get, we're going to talk a bit about two main metrics that are often used in antimicrobial consumption. The first is the defined daily dose, which is a standard metric for drug exposure endorsed by the WHO. It's not only used for antimicrobials, but in our case, we're looking at antimicrobials. The limitation is that the WHO's standard dose is not always a dose that is used in most patients. So that means, let's say meropenem is my favorite example because it's one of the most highly used medications in our facilities in Saudi Arabia, as well as specifically our National Guard facilities. And you can say that there is a lot of work being done on mero because a lot of its use can be improved. So in this case, you can see in the bottom right corner here in the screenshot, this is a screenshot directly from the WHO website, which identifies meropenem WHO DDD as 3. So what this means is that mero is being used here in most situations as 1 grams IV Q8, 1 gram IV Q8. So the total dose of mero used per day in an average 70 kilogram patient is 3 grams. And this is why the WHO DDD is 3. So the WHO DDD is trying to identify for you what is the most commonly used total daily dose of medication X. And we take this number and we use it as a denominator in our numerator. I will show you what I mean next. So however, it needs to be said here that the WHO DDD it cannot apply or actually it skews the data for patients that you include that are on dialysis, or for example, MDR or Pseudomonas. So for those of you in the audience who are already familiar with this type of patient population, you would know that meropenem dose in dialysis would be a lot less than 3 grams per day. And for MDR Pseudomonas, it would usually be double, assuming normal renal function. So what that means is if I get my utilization data for a hospital that's a explicitly dialysis center facility, I wouldn't be able to depend on DDD to compare it to, for example, an ICU. This is how you can look at and interpret DDD. So how do we actually calculate DDD? You can identify, as we said, usage data. This is actual usage data from the National Guard Jeddah that was developed by the pharmacy department, I believe, in 2012. And so, for example, here you see in the top row, meropenem use, you have a 1 gram injection, and throughout the year, you have changes in consumption, and you have a total consumption of 42,000 vials of mero for that year. Once you've identified that meropenem can be used the meropenem DDD from the WHO is 3, you would basically use the meropenem consumption data, the WHO DDD data, and I will show you next how to use that. So for example, here, going back to our example, facility A, let's say, used 42,000 grams, which is the actual usage data here on the top right corner. If you can see my mouse, it's around 42,000 vials. So I'm going to use that number just to make it a bit more realistic for facility A and facility B. On the right-hand side, it's facility B. So facility A used 42,000 and facility B used 42,000. It's a 100-bed facility and a 500-bed facility. So if facility A is at maximum capacity, that means the 100 beds that this hospital has continuously has a patient admitted in that facility. So it will be 100 beds times the number of days, which is 365 in a year, which is 336,500 days. So the DDD for meropenem in this case for 2019 for facility A is 383. If you take the same calculation and the same data, but take into account the difference in capacity, which is 500 for facility B, so the maximum, at maximum capacity, the DDD for meropenem for facility B is 76. So you can see here that if facility A came to discuss with facility B their consumption trends, which should be in the future what we're doing, communicating between hospitals, facility B would be able to say, right, facility A, maybe we need to reevaluate, let's discuss what you're doing and help each other to reduce antibiotic use in this facility. Or even at the more simpler level, if facility A reads data published by facility B, which shows a DDD of meropenem of 76, and compares the patient population and sees that, all right, both of us have ICUs, both of our facilities have a small dialysis center, but of course the numbers are much larger, then facility A would be able to say, right, I really need to do something about my meropenem consumption. So this kind of comparison, you can do it also you can compare your own trends from year to year, of course. This is the main target, to compare your own trends. You can compare trends between different wards. So facility A could say that, right, I actually have, I'm a referral center and I receive some of the patients with the highest rates of MDROs, and this is why my Mero use is so high. You also need to compare between different patient populations and to benchmark to other hospitals, like I said. Right, the next parameter, or the next metric we're going to talk about, I hope DDD is clear enough. So the next parameter we're going to talk about has an advantage over DDD, which I'm going to discuss. So DOT is a single day of drug administered, regardless of number of doses or strength. So it doesn't take into account the dose that is taken. It just looks at if your patient is on 1 gram Q8 and receives, let's say today, which is the 24th of November, my patient received two doses of meropenem because they started Mero at 2 p.m., let's say, and tomorrow my patient received 3 doses of meropenem. And on the day after, they received 1 dose of meropenem. So the DOT for meropenem for this patient is 3, because within those 24-hour calendar day, this patient X received at least 1 dose of meropenem during their day. So it's regardless of the dose. So it's considered by many as a more realistic estimate of use, but it's limited by data available from the electronic system. So as you can see, there is an advantage of using DOT here, especially in pediatric populations, for example, or in situations where you have a lot of dialysis patients, or so the recommendation is to generally use both if you can, both metrics. And there are, by the way, other metrics to talk about, but for now, this is what we're going to discuss. So as I said, you can calculate your DOT by identifying the usage number of days for each antimicrobial order, through your electronic order system or your logistics data. So for example, your patient was on Mero 1 gram Q12 from 1st of January till the 7th of January, so the days of therapy is 7. You divide that number by the patient days. So it would be the total days of therapy for a given month. So let's say you have patient A, B, C, D, and you calculate their days of therapy for all of them. You add them up regardless of patient identifiers, and you divide that number by patient days for that month, and you multiply by 1,000. This is what DOT is. So as I said, we can compare these metrics and say that one may be more useful in another in certain situations and has an advantage over the other. And the recommendation from the CID or the Antimicrobial Stewardship guideline for implementing antimicrobial stewardship published in CID in 2016 is that they suggest monitoring antibiotic use as measured by days of therapy in preference to defined daily dose. Of course, this is a weak recommendation and low quality of evidence, but this is logically what would make sense. So now we're moving on to the next part. I'm going to now, I hope that the calculation or metrics of antimicrobial usage are clear, DDD and DOT. And of course, the next step would be to look at your costs. So you can multiply by your grams used by cost and see how your cost is changing. But for the next part of the presentation, I'm going to be sharing with you some studies that looked at different consumption trends in comparison to hospital-acquired infections and resistance trends. And then at the end, we're going to talk a bit about some of the data that we have here at National Guard. The first study is looking at antimicrobial consumption in 5 adult ICUs over a 33-month surveillance study. This study happens to also be done here at National Guard, the National Guard facility at Riyadh, in Riyadh. So the team looked at data from 2012 to 2015 in 5 adult ICUs. And as you can see here in the bottom left corner, from Q4 2012 to Q2 2015, you have the DDDs and the DOTs calculated. So you can see that there is a change in the trend. There is a general decrease here, but if you are comfortable with quality metrics, but you'll see here there's not really a stable trend. But what they did notice is that in general, carbapenems, if you see here in the second screenshot, carbapenems had the highest consumption. And what they noticed is that there is a high consumption of Mero and Tazo, piperacillin and tazobactam. Mero consumption is higher than other ICUs internationally, and there is a need for a concurrent study on resistance and usage trends, so that you not only have antimicrobial usage trend in the ICU, but also resistance trend in the ICU. As you can see here, this specific recommendation, conclusion, compares the meropenem consumption from year to year within that facility. Within the study, this data is clear, but also it compares it between different types of ICUs, in addition to comparing it to ICUs internationally. And this is how you benchmark your data. Benchmarking means how do I compare to other facilities or other wards. The next study is on antimicrobial consumption in 3 pediatric and neonatal ICUs, also here in National Guard. There are a lot of studies worldwide, but I try to get some that are published here in Saudi Arabia. So this study looked at data over 33 months from 2012 to 2015, looking at 2 pediatric and 1 neonatal ICUs. And they saw that they had 30,000 DOTs monitored. They were able to monitor 30,000 DOTs and 62,000 patient days. The main point here is that you see here they looked at DOTs rather than DDTs and DOTs. And this is, as I mentioned, because of the limitation of using DDDs in pediatrics and neonates. What they found was that, in general, and cardiothoracic wards, they had mostly cephalosporin use, vancomycin and tazo. In the NICU, they had really high aminoglycoside, cephalosporin, and vancomycin use. So if you look at the screenshot here on the right-hand side, you can see that cephalosporin is the highest in pediatric and general ICUs. In pediatric cardiothoracic, it was also cephalosporin followed by vanco. The difference was that in neonatal, which makes sense, from a therapeutics perspective, aminoglycosides and cephalosporins were the highest, most highly consumed. What I've highlighted in red here on the slide was also their observation that cephalosporins, vancomycin, and tazo were used at a higher rate than in pediatric ICUs worldwide. And in the NICU, aminoglycosides were used in as compared to international standards, or not standards, international data. Aminoglycosides were used in a similar way, but cephalosporins, we have higher cephalosporin use in this patient population in neonatal ICU than other published data. So you can see here how this data can be really helpful in defining where do you start your intervention. So often I get asked questions on, do I start restriction? Do we start prospective audit and feedback? And this information that we have now, consumption and resistance trends, can help you define what to do and in which area to focus on. The next study is looking at high contribution and impact of resistant gram-negative pathogens causing surgical site infections at multiple hospital healthcare systems in Saudi Arabia. So this takes consumption into the next level, which compares consumption to resistance trends. So here they're looking at the contribution of resistant gram-negative organisms to surgical site infections. So they've looked at 492 pathogens causing 403 surgical site infections. Gram-negative pathogens accounted for more than 60% of surgical site infections. Most frequent were Staph aureus, and less commonly, but less the MRSA than NHSN. And they found that they had more MDR E. coli versus NHSN hospitals, or versus the comparator standard that they looked at. And so this is just looking at what is the impact of my MDROs on surgical site infections. And then if you take that to the next step and look at antimicrobial consumption trends in that patient population, it would be also very useful. Another study looked at the 10-year resistance trends in pathogens causing healthcare-associated infections, lab-proven healthcare-associated infections. So they looked at healthcare-associated infections proven by culture, and they've looked at the trends from 2017 to 2007 to 2016 at 4 NGHA hospitals. There was 1,500 pathogens causing around 1,500 healthcare-associated infections. 63% of the infections were gram-negative pathogens, and they had increasing Klebsiella trends and decreasing Acinetobacter trends. And in this case, the VRE doubled. So the study clearly discussed how, of course, 2007 to 2016 is quite a nice long range of for the data, and they were able to show how VRE doubled from 2007 to 2016, coming close to the kind of international data, VRE data. So the findings here showed increasing trends of carbapenem resistance and VRE, which may reflect heavy use of carbapenems and vancomycin. These findings may highlight the need for effective antimicrobial stewardship programs, including monitoring and feedback on antimicrobial use and resistance. So you see here that with this study, they try to suggest that they need to link the data to consumption trends. So you see at the beginning we spoke about consumption trends, now we speak about resistance trends, and this is the best thing to do is have both together. One nice way to evaluate your data in case you're not able to have such a rich, long duration of audits and data is to look at a point prevalence survey. And I also presented this yesterday, but this is a really nice way to see how you can start, because in order to have consumption data, you need to have data over quite a while, but you need to start somewhere. What are you going to do today or tomorrow or in 2021 when you're going to start working on improving your stewardship program? You can set up a point prevalence survey uh, during a duration that you decide on. So let's say you can choose 1 day or 2 days or a month where you collect certain data in a specific ward or in a specific or across the hospital for certain antibiotics. So this specific study looked at was a cross-sectional study looking at data over one single day. So this facility recruited all their teams to try to help them get data for over 1 day. They looked at appropriateness of prescribing different antibiotics for different indications in different wards, with or without ID consults. So you see here, it's not only looking at the consumption data, it's looking at appropriateness, which is one of the ways you can also evaluate your data. They found that 54% of patients in the ICU had more than or were on more than or equal to one antibiotic. So that means that half of your ICU was on more than one antibiotic. This identifies a high turnover area, which is expected. They also identified that around half of the patients in surgery were excuse me, more than half of the patients in the study were on more than one antibiotic, inappropriate antibiotic specifically. So 50% of usage was inappropriate, and the highest was in surgery. They were also able to identify that respiratory tract infections were the most common indication for antimicrobial use. Fluoroquinolones were used inappropriately more than other drugs, and ID consultation increased appropriate antimicrobial use. So this study is just a nice way to see how you can link antimicrobial consumption data, which is a usage metric, in addition to process metric, actually an outcome metric, which is appropriateness, process metric, and also look at how you can bring those two together to try to come up with a recommendation of how to move your stewardship program forward. Now I'm going to move to some MDRO data here in Riyadh, which is collected and worked on by the Infection Control Department. So you can see here that the incidence rate of different MDROs per 10,000 patient days. So you see the denominator here is different. It's 10,000 patient days. By year at KAMC Riyadh from 2008 to 2020 is as follows. You can see that MRSA is in the red, Acinetobacter is in blue, and the green is E. coli. I believe this shows, yes, Klebsiella and Pseudomonas and VRE. And these are the rates. So this is just how you can see the trends and how you can decide, right, let me look at 2019. What happened to Klebsiella in 2019? And where was the highest peaks or incidence of Klebsiella in my hospital? And look at ward-specific data, hand hygiene data, and this is how you can also look at consumption data and coordinates with that. Here you can see the incidence rates of different MDROs by location. So ICU is in blue and non-ICU is in red. So you can see on average, except for E. coli, ICUs have a higher incidence rate of MDROs than non-ICUs, which makes sense. And this is one of the reasons why one of our main activities here in National Guard is prospective audit and feedback at ICUs. If you look at incidence rate of Acinetobacter specifically, because we've noticed that Acinetobacter was a concern of ours, and you look at where is the Acinetobacter, you see in this slide from 2017 to 2020 that there is a fluctuation in Acinetobacter rates in the ICU. as well as the other areas, but there's very significant fluctuation in the ICU. But if you look at the data from 2008 to 2020, you'll see that the fluctuation is not as high as it just depends on what the graph looks like. It doesn't mean that it's not as high effectively on patients, but the way the graph is represented can over or underestimate the data. Klebsiella, you can see here a peak in 2019, and then it's the last quarter of 2019, it's going down in the ICU, which is great. And of course, there needs to be a lot of, and there always is here in our facility, a lot of root cause analysis being done and evaluations to see how we can improve. And this is done by the infection control team. And then this slide looks at the incidence of Klebsiella, which is also fluctuating, and then it is going back down. But of course, you see here 2020 is not done, so this data still needs to be enriched. Pseudomonas is fluctuating, and then you look at Pseudomonas in 2008 to 2020, the fluctuation is not as significant if you compare it over a long period of time. E. coli is also fluctuating, but in general, it's a lot less than in 2017. If you look at it over a range of 2008 till 2020, it's also a lot less. And last but not least, in this part of the presentation, it's also important to keep in mind the MDRO incidence rate in the outpatient setting. So if you can see here in the outpatient clinics, they were able to compare Acinetobacter 2008 to 2023. I believe here there's a typo. I believe it. Yeah, it's definitely a typo. It's the 2020. But the point is, you need to look at your MDRO incidence rate in the community setting. So if you're in the community setting is increasing, the rate of resistance is increasing, then you are more likely to start considering how you can adjust your empiric antimicrobial use. But you would need to look at this data on a syndrome-specific data. So it's not just enough to look at community incidence. You also need to look at MDRO incidence in specific syndrome, so UTI, for example, or pneumonia. So moving on to the last part of the presentation, how do we look at NGHA DOT cost data here? What are we actually doing? We're currently we have been working on DOT data from our well, it's not new anymore, but getting data from our best care system. It's currently under last step of validation. But I will show you some data that I have for, this is the Western region, so this is National Guard Jeddah. So the goal here is to create easily accessible, for our leadership, easily accessible data on days of therapy, and then also translate this information to also DDD. And if you can see here, there's a clear reduction in consumption from 2016 to 2020. Now, it's important to note that this is a draft, it's under validation. Please don't take these numbers as a final number, but in general, excuse me, we were able to see that at least there's a trend in that's reducing. And when we are validating the data, we were able to see that this trend is true. It's actually accurate. And what then would be your answer to this kind of data? You would look at what interventions were you able to do during this time. Education, we had antimicrobial stewardship champions across the hospital. We had perspective audit and feedback in certain parts of the hospital. So we did adult ICU, pediatric ICU, hematology, oncology, and actually that's it. Adult ICU, pediatric ICU, and hematology, oncology. So what you see here is, and this was starting mostly in 2016 2017. We had to have a break and then restarted in 2018 heavily. But you can see a clear trend in reducing antibiotic use even before we started our restriction program in 2019. So you see here in 2019 quarter 1, there's a clear also reduction in antimicrobial use, and the reduction is still ongoing. What's also interesting is that we also have a general reduced use of meropenem, which is in red, in addition to a reduction in other antimicrobials. All right. Next is also we looked at even more details on DOTs per 1,000 patient days for restricted antimicrobials. So we wanted to see the impact of restriction on DOTs, and there is a clear reduction in usage in 2019. You can see that tigecycline reduction was significant. So was for imipenem and meropenem. And on the right hand side, you can see the reduction in caspofungin and linezolid IV and voriconazole IV use. It's also important to note that in general, whenever you have an intervention, you can't just look at, for example, the restricted medications. You also have to look at the other medications, the other antimicrobials that may be affected. So, for example, we were able to observe that there was a clear reduction in overall use of restricted medications. You can see here on the right-hand side the percentages. But other level 2 restricted medications, such as aztreonam, were not introduced till mid-2019, so they're not included in the analysis. On the right-hand side, you can see here that there was a decrease in non-restricted antimicrobial use, such as norfloxacin, ciprofloxacin, tazo, gentamicin, Bactrim, and other medications. And there was an increase in anidulafungin, linezolid, oral, cefepime, augmentin IV, and nitrofurantoin. And you then need to identify why was there an increase. So there was an increase in cefepime, augmentin, and anidula, and linezolid oral, probably because we're squeezing the balloon. If we restrict linezolid IV, then people might instead, some will stop ordering linezolid because they then see the point of why we don't need linezolid in those patients, but some may start using linezolid oral. If we restrict meropenem, it's more likely that we will either de-escalate to cefepime or tazo, or we will, it's just that people will stop prescribing meropenem in the first place and use cefepime. Interestingly as well, nitrofurantoin consumption increased quite a bit by around 5-fold, and this increase was due to heavy education on the utility of nitrofurantoin in UTIs in comparison to ciprofloxacin and Bactrim in our facility, based on our antibiogram for urinary antibiogram in the outpatient setting. Cost report. Now we're linking utilization to cost, and you can see here that there was a significant cost reduction of around 2 million SARS, even after including the newly added medications that are expensive. So it justifies that we are doing a relatively good job, at least at not increasing cost by adding the new antimicrobials. The last part I want to just discuss is that I know we've discussed antimicrobial usage trends, utilization data, resistance trends, but also there's just a really important source of data that you can get to help you make decisions, the antibiogram. In National Guard, for those of you who are attending from the National Guard, you can easily get the antibiogram from our intranets under pathology and laboratory medicine, depending on your region. And you can see here on the left-hand side, on the right-hand side, there is a screenshot that shows the antibiograms over the years. So how can you use the antibiogram? This is a plugin just to support stewardship and understanding the antibiogram. You can see here, for example, E. coli, from which is this antibiogram is in the outpatient antibiogram. The E. coli susceptibility pattern identified that nitrofurantoin here is 89% susceptible, as opposed to 51% in Cipro and 54% in Bactrim. And this is also why we should pushed to use nitrofurantoin in uncomplicated cystitis in women instead of Bactrim and Cipro, because you're more likely to pick up your bug with nitrofurantoin. Also, we're working on comparing the antibiogram over the years. This slide is just here to show you how complicated it could seem sometimes to compare things, but you need to be able to take things step by step and compare your data over time. So I hope this presentation was useful enough to be able to help you define how you can utilize or understand consumption trends. DDD and DOT are just big words for consumption trends that are standardized based on a preset pre-decided on denominator. Antimicrobial resistance trends are really important to use in conjunction with antimicrobial use trends. Don't forget to speak with your microbiology team and with the infection control team to try to get the best data possible. Right, I will leave the floor open for questions now, if there are any.
Thank you, Dr. Noor, for this great presentation. I'm trying to see if we have questions, but if you don't mind, I have one question for you. I was interested to see to get more information on the rate of MRSA from like an outpatient arena or like community acquired MRSA. I believe you presented it, but it was in like 10,000 per. Yeah, 10,000 patient day. Do you have it like in percentage? Yeah, I believe the slide.
Sorry, I was on mute. No, I don't have it in percentage. Let me.
I see there is a trend, right? There is like increase.
Yeah, so the data I'm showing. I don't know if you can you see my slides right now?
Yes, I can, yeah.
All right, so I didn't present, of course, all the data because it's quite significant, but the data that I have here is for inpatients. I don't have outpatient data for MRSA at this point in a percentage because you know
okay.
Actually that Dr. Haja, this is a good question. Do we look at data in percentage or do we look at where is the twin? There it is, I think. Yeah.
Yeah.
Do we look at when we look at MRSA data or any data resistance data as percentage, it's like the antibiogram, I guess. So this is what you could use. Let me look for the antibiogram here. Actually, if I.
You mean utilizing like the EED antibiogram? Yeah.
Actually, okay, you can see my slide now, right?
Yes.
All right. If you see here in the bottom, which is the 2019 outpatient antibiogram slide, MRSA here from the outpatient setting, they had 116 isolates that are resistant to Staph aureus that were included here in the evaluation. But even if you came to look at this data, it wouldn't be realistic to say that over 1 year I only had 177 MSSAs and 116 MRSAs. So this data kind of just gives you helps you focus on susceptibility trends of the antimicrobials, but you would have to take an extra step to look at percentage in a different way. I hope that so in summary, no, I don't have the data right now.
Okay, thank you.
Sure.
Let me see if there is any questions here. Yeah, I think that's all for today. Thank you so much, Dr. Noor, for this presentation. It's almost 10 o'clock.
All right.
Yeah.
Thank you
very
much.
Have a good day, everyone. Thank you.
All right. Thank you, Dr. Hajan. All right. Awesome. Welcome, everyone. My name is Noor. I'm an antimicrobial stewardship and infectious disease clinical pharmacist. We're going to be talking this morning about viral versus bacterial infections with Dr. Henry Bafobani, who is a consultant in infectious diseases. And He's fixing his slides now, but he'll be joining us shortly. He's a consultant in infectious diseases, and he's heavily involved in antimicrobial stewardship activities here in National Guard Riyadh. He will be putting up his slides shortly.
Okay.
Center 23.
Are they showing now?
Can you?
Hmm? I guess we should put it here. No,
Great.
can you see it now?
Yes, we can see your slides clearly, and we can hear you.
Okay. Well, good afternoon, and thank you very much for this invitation. My lecture today is basically simply stated bacterial versus viral infections, and I'm going to present a case, and through the case highlight the daunting task that we always face clinically in distinguishing bacterial versus viral infections. And after that, I'm going to describe certain modalities which we can employ to help us in tackling this ever-present problem that we have. Now, to begin with, let me show you this slide, which is from a CDC website, which basically highlights the dilemma we clinicians face all the time in distinguishing bacteria from viruses as a causative agent of infections. When somebody has a sore throat, TB, whooping cough, a UTI, the diagnostic challenge is very minimal. We know the causative agent is a bacterium, and we tailor our antibiotics in that direction. Those are very clear. And also at the other end of the spectrum is when we have somebody with a common cold, influenza, or certain forms of sore throats without exudates. We know that is virus. And we do not give antibiotics, or at least we are not supposed to give antibiotics. But lying in the middle are disease entities like bronchitis, sinus infections, ear infections, where we are not so sure whether they are being caused by viruses or bacteria. In that case, whether or not to institute antibiotics becomes a challenge. And this is the reason why it's estimated that, at least in the outpatient setting, various studies have indicated that the vast majority of antibiotics used are unnecessary. And the consequences we all know are increasing resistance and sometimes even morbidity and mortality. So the diagnostic challenge always remains how to distinguish a virus-mediated infection from a bacteria-mediated infection. And admittedly, that is not easy at all. Now, to highlight this, and also in concert with current times, I want to present a case. I mean, the diagnosis in this case is very certain, but I think we need to go through the case sequentially to bring out the salient points. We have a 62-year-old male with poorly controlled diabetes, hypertension, morbid obesity, and COPD who presented with a 4-day history of fever, a mild productive cough, debilitating myalgias, and loss of sense of taste and smell. The chest X-ray showed bilateral perihilar infiltrates. The patient was hypoxic with a PO2 of 88% on room air. The serum ferritin was elevated at 1200, and a rapid COVID-19 screen in the ER was positive. As you can well imagine, this patient warrants admission to an airborne isolation room. Now, this is not uncommon in these times. The vast majority of patients will not present with this scenario requiring admission. We know that the vast majority are probably going to be asymptomatic and a significant number have mild symptoms. But we do see patients with COVID-19 who require admission because they are hypoxic and they have significant pulmonary infiltrates. But the big question is, this patient as presented now, should this patient receive empiric antibiotics? Now, in the past few months, we have been seeing a lot of COVID patients admitted, and I would say a significant number of them are on antibiotics because presumably they came with pulmonary infiltrates. And when you start somebody on antibiotics, of course, the thinking is, your suspicion is that the patient has bacterial infection. But in this patient presented, the rhetorical question is, does the patient really need antibiotics? Now, luckily we have data to back us in our decision to start antibiotics or not. There was a meta-analysis done by Langford et al., which is published in Clinical Microbiology and Infection this past July, which evaluated a cohort of 1,308 studies, of which 24 of them were deemed pertinent, and the group represented 3,338 patients. And basically what this meta-analysis sought out to examine is whether there is bacterial co-infection at the time of presentation of COVID-19 and also after admission, that's secondary infection after presentation. The findings I will summarize here. Bacterial infection was found in 3.5% at presentation and 14.3% after presentation. Most interestingly, the bacterial infection was found to be more common in patients who were critically ill, 8.1%. And as I alluded to in the beginning, the vast majority, which in this case, this meta-analysis represents 72%, but my personal experience is in our facility is probably higher than that. 72% in this study received antibiotics, whether they needed it or not. So let's compare this to influenza. Influenza, we know, back in 1918, the majority of the reason of death for most patients was due to concomitant superinfection with bacteria, most notably Staphylococcus aureus. Now, there's a meta-analysis of 27 studies done by Klein et al., which evaluated a similar number in the previous group, in this case was 3,215, to find out whether there was co-infection with bacteria in patients with influenza. What he discovered in the meta-analysis was a very wide range of infection rate, ranging from 2% to 65%. But the long and short of it is, on balance, bacterial co-infection in influenza most certainly is higher than in COVID infection. Prior studies have identified the young and unvaccinated group to be the most likely to develop bacterial co-infection. So basically, when compared to influenza, these two meta-analyses suggest or even prove that bacterial superinfection is much more prevalent in influenza infection as against COVID-19. So what do we make of all this? How does this translate into clinical practice? What is the recommendation? Well, the implications seem to be that COVID-19 typically does not present with bacterial co-infection. And as a consequence, empiric antibiotic therapy should be avoided in COVID-19 patients at presentation, assuming there's no strong, compelling evidence that there is concomitant bacterial infection. Now, having said that, I should emphasize the fact that if at all possible, sputum cultures should be obtained in all admitted patients with COVID-19 infection. Now, having said that, we know that COVID-19 a lot of times will present with a non-productive cough. So if you set out to obtain sputum, that might mean sputum induction, which is not probably the wisest thing to do because you might have aerosolization of virus. But if at all possible, obtain a sputum culture in this patient. And in critically ill patients who there are other reasons to suspect that the patient may have concomitant bacterial infection, such as recent hospitalization, prior infection, or colonization, those with bronchiectasis, especially patients with bronchiectasis who are colonized with Pseudomonas and other gram-negative pathogens, may very well present with dual infection with COVID-19 and bacteria. This is a clinical decision that needs to be made after a thorough history and review of the record. But for all intents and purposes, for simple, uncomplicated COVID-19 patients admitted with pulmonary infiltrates and a positive COVID-19 test, empiric antibiotics should be avoided, or at the very least, I would say, are very much discouraged, because the evidence at hand do not support the view that there's frequent co-infection. Now, there are other means by which we can tease out bacterial infection from viral infections and lower respiratory tract infections. One of the modalities is by employing the multiplex PCR, where basically an assay will go through a run of PCR tests to detect commonly encountered bacteria. The method is highly sensitive, but does not detect all bacteria, unfortunately. And also, this requires batch processing in most labs. In other words, if a single patient comes in, you cannot do a multiplex on that. You can do it, but it's not cost effective for the lab to do it on a single patient. And for busy places, this is not an issue, but for smaller facilities, batch processing is the way they go about it. Now, I mention this because the results may not be immediately available. It's a rapidly evolving field, and I think the leader of the pack in this area is the BioFire film array, which actually can give you results in an hour. And it gives you results based on, bacteria, which are these are the most commonly encountered bacteria. You can get results in an hour if you're infected with any of these, and also atypical bacteria. And also included in the biofilm array pneumonia panel are commonly encountered viruses, including MERS. Interestingly, this modality will also give you, can also detect certain genetic mutations leading to resistance, the MECA mutation in MRSA, and KPC, and the new Delhi metallobeta enzymes, and OXA48 and CTXM, and these are, can be detected within an hour. It's a very powerful technique, and I think the NGHA has this technology, if I'm not mistaken. Now, the other modality by which we can employ to tease out bacterial infections from viral infections is the procalcitonin. And I'm going to spend some time on this because it's something which is gaining currency, but I will mention that the way the assay is used varies widely from center to center. There's no clear-cut protocol to use calcitonin. And also, it cannot be used by itself. You have to combine it with clinical judgment. In patients with community-acquired pneumonia, studies have indicated that the procalcitonin is about 70% accurate in distinguishing bacterial from viral infection. And as I mentioned before, it has to be part of an algorithm. Clinical judgment is very important. You cannot use it by itself. But when used appropriately, other studies have shown, and I'll provide the references to anybody who desires to probe into this, since they are not listed here. But by and large, appropriate use of the procalcitonin with clinical judgment has been shown to decrease unnecessary antibiotic use from about 25 to 40% without increasing morbidity and mortality. So let's talk about procalcitonin. What is procalcitonin? Now, procalcitonin, in the absence of any systemic inflammation, is produced by thyroid neuroendocrine cells. Now, the production is limited to thyroid tissue and is actually not released into the systemic circulation until it is cleaved into its mature form, the hormone known as calcitonin. So for all intents and purposes, in an otherwise normal, healthy adult or subject, if you check the serum procalcitonin, it will be undetectable. You are not supposed to have procalcitonin in your blood. But when there's systemic bacterial infection, the limitedness of procalcitonin production in the thyroid is not the case. All tissues in the body, upon stimulation during systemic bacterial infection or otherwise, will produce procalcitonin, which is then released uncleaved into the systemic circulation. This distinction is very important, and I'll go through the false negatives and false positives in a minute. Now, how about the kinetics of procalcitonin? When there's an appropriate stimulus for the production of procalcitonin beyond the normal physiologic levels produced in the thyroid, such as during bacterial infection, the level rises 2 to 4 hours after the initial stimulus. In other words, you have somebody infected with bacteria. Within 2 to 4 hours, the procalcitonin starts to rise in the blood. And it peaks anywhere between 12 to 48 hours. Various studies indicate otherwise. Some people say it's 12 to 24 hours. Some people 24 to 48 hours. But the long and short of it is, by the end of the second day after the initial stimulus, your levels will peak. And if that stimulus is removed, in other words, the infection is resolving, the inflammation is abating, then there's a decline of the procalcitonin at the rate of about 50% every 1 to 1.5 days. Now, I'm going to go through the utility of using procalcitonin, at least in some studies, to follow patients and make a decision as to whether you should stop antibiotics or not. Now, this table here, obtained from UpToDate, is rather, it's quite loaded, but I'll go through it sequentially. We know that procalcitonin is stimulated, production of procalcitonin is stimulated by bacteria. And a level greater than 0.25 is typical for most bacteria. Atypical bacteria will cause a rise in the procalcitonin, but not as high as typical respiratory bacteria. I should mention that mycobacteria also can cause elevation of the procalcitonin, at times even greater than 0.25. What to note here is viruses do not cause an elevation of procalcitonin. And the reason is thought to be production of gamma interferon by viruses, which inhibits the production of tumor necrosis factor and other cytokines by the virus, which lead to non-production of procalcitonin. Certain parasitic infections, most notably malaria, can give you mild elevations of the procalcitonin. And one thing that you should note is those with severe C. diff colitis can have elevation of the procalcitonin. Even Clostridium difficile colonization can lead to elevation of the procalcitonin. These become clinically relevant when, as a clinician, you have to digest information and assign reasons why a procalcitonin is elevated. And we'll get to that in a minute. It is important to note that trauma by itself, burns, any type of surgery, reasonable extensive invasive surgery, bowel ischemia, those who bleed in the brain, stroke, and anaphylactic shock from allergies or cardiogenic, these are conditions that can lead to a rise in the procalcitonin and cause a false positive in terms of, in your assessments of whether there's a bacterial infection or a viral infection. If you have concomitantly any one of these factors, then you should understand that that can cause a rise in the procalcitonin also. Immune disorders, lupus, rheumatoid arthritis, temporal arthritis, polyarthritis nodosa, even gout and pseudogout can cause a rise in the procalcitonin not to a significant degree. Of the immune disorders and rheumatologic conditions, Kawasaki disease stands out in causing a marked rise in the procalcitonin. I don't know the reason why. Now, you should understand that of late there has been interest in Kawasaki-like disease, which is known to accompany the presentation in COVID-19 in some children. So I mentioned this for the reason that, Kawasaki disease is known to elevate the procalcitonin quite significantly. Malignancies, especially thyroid cancer, and that's not surprising. Lung cancer, also those with neuroendocrine features, can lead to elevation of the procalcitonin. Other cancers like lymphoma, sarcoma, pancreatic cancer, and renal cell carcinoma can lead to a mild rise in the procalcitonin also. And medications. And this is important because when somebody is on steroids, that can lead to a mild elevation in the procalcitonin. And certain TNF inhibitors, interleukin-2, rituximab, and T-cell antibodies can lead to a rise significantly above 0.25. So I think this table is very important. At least having a knowledge of this helps you interpret an elevation of procalcitonin, which you can juxtapose with your clinical evaluation to help you arrive at a very sound clinical judgment. So, what is the utility of procalcitonin? Procalcitonin typically is used to help you discontinue antibiotics, and I'll go to that in a minute, to help you ascertain whether this is indeed a bacterial infection and not otherwise. It has a limited role in initiation of antibiotics. It's quite controversial. Now, all the papers that I read made mention of the fact that in critically ill patients, institution of antibiotics is probably wisest empirically in patients who are critically ill, febrile, hypertensive. You don't know what is going on, so it's probably wisest to use antibiotics at that time. The big question is how long to keep patients on antibiotics, and from a stewardship standpoint, when to discontinue these antibiotics. As mentioned, procalcitonin has been found to be most useful in influencing antibiotic discontinuation in suspected community-acquired pneumonia cases. And indeed, some studies have shown that it can decrease antibiotic use for up to about 3 days, which is significant. Now, this study here, which is from JAMA from 2009, evaluated a procalcitonin-based guideline versus standard hospital guidelines in the use of antibiotics in lower respiratory tract infections. Now, the issue at hand is following a guideline, which may vary from institution to institution. As mentioned in the beginning, there's no standard way to use procalcitonin. Most institutions have developed their own algorithm, and I don't believe we have one here. But at least, and I'll get your input on this now in the question section. So here I'm going to present to you the author's guidelines and how it helped them to make that important decision of stopping antibiotics. I think this is very important in teasing out bacterial infections from viral infections. The results of the study, and which you can access the whole study later on, I'll read the conclusion here, is in patients with lower respiratory tract infections, a strategy of procalcitonin guidance compared with standard guidelines resulted in similar rates of adverse outcomes, as well as lower rates of antibiotic exposure and antibiotic-associated adverse effects. Okay? As mentioned, in the case of community-acquired pneumonia, there was a 30% reduction in antibiotic exposure. Let me go through this algorithm that the authors use, which I believe you don't have to follow the same algorithm, but I think it sheds some light on using this all-important test, in my opinion. Now, let's say you have a patient who you start empiric antibiotics on because of suspicion of community-acquired pneumonia. You don't have culture results, but your suspicion for community-acquired pneumonia is strong. You obtain a procalcitonin initially, and it is high, and the patient is on antibiotics. The decision is when to stop these antibiotics or when to de-escalate. The authors recommend obtaining a procalcitonin every 1 to 2 days. Now, in any one of such patients, there is a clinical suspicion by the physician. If you think the patient very likely may have bacterial community-acquired pneumonia, the reason for obtaining the procalcitonin every 1 to 2 days is to find out whether the levels are declining. Let's say the levels are declining. That fortifies your belief, and you move towards considering discontinuing the antibiotic. The levels are indeed declining, and they are less than 0.25. If they are less than 0.25, then you probably are right if you discontinue the antibiotics when they've had at least 5 days of appropriate therapy. Suspected bacterial community-acquired pneumonia, procalcitonin headed south, decreasing less than 0.25, you can stop antibiotics, according to this group. But let's say the procalcitonin is decreasing, but it has not gone below 0.25. Does that mean you have to continue antibiotics? or stop them? Well, if they have gone down at least 80% and peaked around greater than 5, and they've gone down 80%, according to this algorithm, antibiotic discontinuation is encouraged. If they have not gone down more than 80%, you continue antibiotics. Okay? Now, the other thing here is those with suspected viral community-acquired pneumonia, but you started antibiotics empirically waiting for cultures. If the procalcitonin is less than 0.25, then concurrent bacterial community-acquired is unlikely and antibiotic discontinuation is encouraged. Okay? If the procalcitonin is still high, then you have to think of other reasons why the procalcitonin may be elevated. Okay? Now, this is viral community-acquired pneumonia, so the patient is most likely not on antibiotics. But you can have this and elevated procalcitonin at the same time. In that case, then you revert back to the table that I showed to find those with probable, alternate reasons why procalcitonin may be elevated. And then we have non-infectious causes of procalcitonin elevation, and we've gone through that. Okay? Now, I would like to spend some time on, a topic which is very dear to me. Okay, now, we are trying to distinguish bacteria from viruses in causing infection. And we have gone through the use of the bacterial multiplex and the use of procalcitonin. These are modalities which can help us make that distinction. But probably the most powerful modality available to doctors is the physical exam and the history. And that seems to be disappearing, okay? Multiple studies have shown that a careful history can uncover evidence that what the patient has is a viral infection. For example, if there was a group of people got sick with runny nose, sore throat, watery eyes, and the patient was exposed to that group, if you take a careful history, that might lead you to that, and you can safely assume that it was a viral infection going on through the community, and he was a victim, and basically antimicrobials are not needed, okay? And in the case of bacteria, a careful physical exam can reveal things like agophony, pulmonary dense consolidation, which are not typical for viral infections, by the way. So I'm putting this slide up to highlight the fact that there's a disturbing trend of physicians not listening to patients and not even touching patients and relying on labs and radiographic studies to make their decision. But going back to the old-fashioned way of actually taking a good history, doing a good physical exam can save you a lot of headache and when making this distinction. I remember when I was a resident back in Atlanta, Georgia, we had a patient who came in with pneumonia, and we started at that time, there was a drug called Zinicept, sulfuroxine, and we kept the patient on. It's a young woman, I remember, this is over 15 years ago, kept the woman on for about 7 days. She didn't get better. And the medical student who was working with me went back and took a thorough history, a very thorough history, and came back and said the patient had been exposed to a sick bird. The bird was outside her window, and being as good as she is, took the sick bird into her house to nurse the bird. And the patient ended up having infection with chlamydia psittacosis, which the drug of choice is doxycycline. So we gave this patient 1 week of cefuroxime, Zinicef, a second generation cephalosporin, for no reason other than pure knee-jerk response. If we had taken our time, or I had taken my time, to take a careful history, we could have avoided the use of this second generation cephalosporin, which undoubtedly led to the selection of resistant pathogens in this innocent patient. So in as much as we are armed with all kinds of modalities to help us, CT scans, MRIs, calcitonin, multiplex, I think the good old-fashioned way of taking a very good history and doing a thorough physical exam can never be duplicated. Thank you very much. This is the end of my discussion.
Thank you, Dr. Henry, for that very practical approach to antimicrobial prescribing in patients who may have viral infections. I have a few questions here for you. First of all, what would you say the role of a patient would be in differentiating between viral and bacterial infections themselves, or not differentiating, but because a lot of us are patients as well as healthcare workers.
Yes.
So if I were to be a patient and I started having symptoms of any kind of infection, when would I consider that I need to go to a physician as opposed to like just managing my symptoms at home? And what are some maybe common flags for concern for bacterial infections and for common infections like pharyngitis and things like that?
This is a very good question, and there's no one right answer to that. And let me just say this. You know, sometimes we tell patients that, oh, if you have a fever, you know, stay home, don't come to work, right? And some of these patients will do, I mean, a lot of them will do well, especially in these times of COVID. But at the same time, there are instances where patients decompensate and they call the ambulance, and some people have died, unfortunately. So the answer to the question is, I think if you have symptoms of a URI, a cough, runny nose, and you have high fever, at the very minimum, I believe that you have to present yourself to a healthcare establishment for assessment. I am very reluctant to tell febrile patients with probable pulmonary infection to fend for themselves at home. You never know what could happen. There have been instances where people have done very well, even with fever at home, because we know the patient may have COVID, they are not hypoxic, you know, and they are just hanging in there. But my threshold to presentation is low because of my experience with patients decompensating at home. You can never tell, and I know there's no one right answer to that.
What about so this is clear with the symptoms such as cough and fever, and you know that anytime there's fever, there needs to be a better assessment with the healthcare worker or physician specifically. It would be, I'm a pharmacist and I would advise against going to a pharmacy to just get you know an antibiotic. That's for sure. That's the purpose of our talk today. But what about symptoms of, let's say, just pharyngitis? Someone who's had, you know, cough, no fever, they've had the sore throat for a couple of days. When would patients think, right, this is the time that I need to consider going in because this is the time that I may need an antibiotic? Is there a duration of time? Is there, you know, what could?
Well, I think most authorities would say that if symptoms go on beyond 3 to 5 days, then an assessment is probably warranted. Definitely not on day one, no. So I would say 3 to 5 days of unresolved symptoms with fever and non-improving sore throat, you might want to seek attention.
Yeah, exactly. Yeah. So this is just thank you for that. The other question I had was about using rapid diagnostic tests in the community. Have
Sure.
you been exposed, or have you been able to use rapid strep tests, for example, to differentiate between viral and bacterial infections in the community setting?
Yes, there's a rapid strep test, but that's specific for Streptococcus pyogenes. You understand? That will not distinguish, for example, a significant percentage of patients have Acanobacterium, causing sore throat, and other non-streptococcal bacterial sore throats. Okay, but where there's Streptococcus pyogenes, the rapid test is very helpful.
Yeah.
But having said that, not all bacterial pharyngitis are caused by Streptococcus pyogenes.
Yep.
There are other, modalities, there are other entities like Acanobacterium and stuff. But by and large, it becomes a clinical decision. If there's visible exudate on the pharyngeal wall, there's palpable tender adenopathy, there's no concomitant rhinorrhea or viral symptomatology, then you are justified in empiric antibiotics. But you need to examine the patient. You understand? It's not something that you get from the patient just telling you. The healthcare provider has to examine the patient to come to this conclusion to give the antibiotic.
Great, thank you. I have a question here that is trying basically possibly to summarize. When should we use procalcitonin? I'm assuming the person asking is asking about the specific situation, but would you maybe summarize in a minute, when should we use procalcitonin?
Good question. The answer is, it's very, like I mentioned at the beginning of the talk, there's no standard protocol, and just in Jeddah, I think you had a protocol of using procalcitonin. Am I wrong?
Yeah, yes, we did, yes.
Okay. So, but as a general rule, I don't think most institutions have guidelines to use procalcitonin. So it becomes the physician's prerogative to use it the way he or she wants to use it. Okay? So what I just presented was a cohort of physicians and the way that it has helped them. So the answer to the question, when should you use procalcitonin? This is how I'll answer it. I do not believe procalcitonin should guide you in the selection of antibiotic, whether to make a decision whether to start an antibiotic or not, because it's not a test which will give you immediate results. You understand? If you need to make a decision on the spot, procalcitonin will not help you. I think the utility of procalcitonin is after the patient is on antibiotics, a decision to stop it. In that case, I believe there's some utility to it. And sequential procalcitonin determination, according to this algorithm I presented, can be useful. It can be useful in giving you the fortitude to stop antibiotics. It's never easy to stop antibiotics. I will admit that as an ID specialist. Sometimes I listen to physicians explain the reasons why they have patients on antibiotics, and I can feel their distress. You understand? I can feel their distress. They are caught between a rock and a hard place. But I believe the procalcitonin, when used in conjunction with clinical judgment, can be beneficial and help you make a case for stopping antibiotics, but not starting antibiotics.
Nice. So a couple of more questions. I know you've presented yesterday about the concept of watchful waiting.
Yes.
Would you mind giving us an overview of, the summary of what watchful waiting is and how it can be applied in the setting of viral, bacterial versus bacterial infections in the community setting?
Very good question. The concept of what, obviously, when somebody comes in with a blood pressure of systolic blood pressure of 80, a fever of 40, respiratory rate of 45, I mean, you're not going to wait, are you? No. You have to do something. But occasionally, I will have instances where a case is presented to me with somebody with a fever for the past 1 month. You understand? Comes into the hospital. They may have an infection, they may have a connective tissue disease, or they may even have a malignancy. In that case, and as soon as they get into the hospital and give a history of had a fever for 1 month, sometimes antibiotics are started. In this instance, I believe, even though the patient continues to have fever in the hospital in the initial stages, you are justified in withholding antibiotics until you get some initial results back. The definition of watchful waiting becomes really pertinent in this instance. The patient has had fever for 1 month, comes into the hospital, you see the patient for the first day, you don't know what is going on. I believe you can wait a little bit until things are clearer, okay? If there's no fever and all you're going by is lab data and clinical improvements, sometimes you can wait with such patients also. You know, most people who write antibiotics, there's a perception of fear that if I don't do this, this may happen and I'll be blamed.
Yeah, the
So
what if.
for myself, let me just do it and nobody can blame me. You understand?
Yeah.
And the reason why this way of thinking has gained prominence is the effects of inappropriate antibiotic use are not immediately palpable. You can see them. They sort of develop slowly when you're using antibiotics inappropriately. But when you do not use antibiotics, the effects are immediately visible.
So would you say, for example, go ahead.
So the concept of watchful waiting becomes very difficult for some providers because they are living under, especially in societies, I came from the US, which are very litigious, that, you know, there are lawyers coming at you and all that stuff. You always are thinking, let me cover myself by giving antibiotics, okay? But where, you know, there's no reason to suspect that the patient would decompensate, I think watchful waiting is appropriate. In this hospital, I have waited a day or two to get results of a urinary tract infection when I believe clinically the patient has a simple cystitis, and within 12 to 24 hours, I'm going to get the right pathogen, and I don't just want to give something empirically for no reason. I've done that, and I've gotten away with it, okay?
What about prescriptions that can be refilled upon need of a patient? So instead of watchful waiting, let's say, sorry about that, but instead of watchful waiting, giving a patient a prescription because maybe they may have difficult access to come back to the clinic to take another appointment, you may give them a prescription and wait to see, ask them to fill it or use the antibiotic if they think they need it within 24, 48 hours.
I think that is a modality that we need to start emphasizing around here, the concept of delayed prescriptions. In societies where they've used them, this modality, they have worked beautifully. We talked about it yesterday. The National Health Service in the UK utilizes that modality. In the Scandinavian countries, they use it a lot. And the studies, large studies, by the way, show that when you offer a delayed prescription, like I mentioned yesterday, more than 60% do not fill it, especially when you suspect a viral infection. Okay. They may be a viral infection with concomitant bacterial infection. If that is indeed the case and the patient doesn't get better, they will fill the prescription. But in the lower respiratory tract infection, where we know majority of the pathogens are viruses, which are self-limited, the studies that I presented yesterday showed that over 60% never filled the prescription. So I think that is a modality which we need to encourage here. I think
or perhaps in pediatric cases where parents are really scared and they are pushing to use antibiotics with, for example, they're pushing although there's some data that suggests that actually patients don't ask for antibiotics all the time. It's physicians that are afraid of the patient's perception and that's why they prescribe. But there's this like just unclear path between physicians and patients. So sometimes maybe that could help.
Definitely. I think like I mentioned, a lot of physicians have the fear that, if I give antibiotics, I'm buying some form of insurance. Okay. And I think part of our educational program needs to be directed at physicians who have that type of thinking. And admittedly, it's not easy. It's not easy at all. I have told many people about my personal experience with family members who think I'm the worst doctor in the world, okay, because I don't give them antibiotics because they have fever. And then they go to somebody else for it, okay? So.
Okay, great. So I have just to comment on your question about having procalcitonin policy. So yes, in Jeddah, in National Guard Jeddah, we had a procalcitonin policy which describes when to use procalcitonin. We elected to use it in sepsis and septic shock only at the time because this was 2018 when this policy was developed and the data on lower respiratory tract infection use of procalcitonin in lower respiratory tract infection was not as strong as the recent developments. There may be still facilities who choose not to use procalcitonin at all, some who choose to use procalcitonin in sepsis or septic shock, and some who choose to use it only in pneumonia. So it depends on the facilities, if they want to pay for it. And with procalcitonin as a policy, you need to also have a stewardship program to enforce its use in the best way possible. So that's what I just wanted to share that with you.
Yeah, but I think the algorithm which I presented, which I was taking from Up to Date, I believe the authors have a very strong case to make in using procalcitonin sequentially to guide them to discontinue antibiotics.
Yes.
We encountered that a lot. Sometimes somebody is on antibiotics and they set a date of 14 days, okay? And it's empiric. And I bet a vast majority of people who fall in this category may not even need it.
Yeah. And so this brings me to the last question here. One of the audience members asks a very important question. Can procalcitonin help us in antibiotic use in COVID-19 patients?
Very, very important question here. I did not mention that, and I probably should have, that COVID-19 in itself can raise the procalcitonin very minimally, okay? So the studies, I don't think they've done any studies to really pin down what is going on, but it needs to be used with caution in patients with COVID-19. The initial, you can go to the Up to Date session, which is available, I believe, online at the National Guard for everybody. In the opening chapter, they mentioned that the use of procalcitonin in COVID patients is not something which we know much about. All we know is in those with COVID alone, without concomitant bacterial infection, the value is spuriously increased a little bit. The clinical significance of that, we do not know. So I would use it with caution.
And I think you mentioned, I believe yesterday, that in COVID, the risk for bacterial infections, I don't know, it was today, I'm mixing my days up, that the risk of bacterial infections within the first 7 days is not as high as it would be with influenza. Exactly. So even regardless of COVID, this goes back to your comment about thinking about the clinical situation, about the patients, how the patients is presented to you before you even think about getting any tests or lab tests or microbiology evaluations. So first to think about the patient and the risk factors, I guess.
Exactly, yeah. But the fact still remains that, and we have seen this on prospective audit rounds, when a lot of COVID patients automatically started on antibiotics. And what makes it even worse is most of them, they don't even get sputum cultures, okay?
Yeah.
Because the patients may not be coughing.
Mhm.
But I think the word needs to go out, and strong. We need to make a very strong point. The COVID-19, unlike influenza, at presentation is very unlikely to have bacterial co-infection. And antibiotic use empirically is strongly discouraged. I think that has to go out very strongly.
Absolutely, absolutely. All right. Well, thank you very much, Dr. Henry. This was a pleasure. I think we are, unless you have anything else to add, there are no more questions at this point. I've personally enjoyed the presentation. So, and for our audience, thank you for joining us. I hope you've benefited. If you have any questions, please, within National Guard, please feel free to contact either Dr. Henry or I. Thank you.
Thank you.